to my presentation here. Thank you to Professor Alper for inviting me for the meeting here. It's a great honor for me. My theme is what is the value of commonly used SPAF risk scores in current era? Is it time to review? My name is Dr. Alexander Wystrach. I come from Bamberg in Germany. Here you see our clinic. It's a city with 70,000 people in Germany. It's a very pretty scape. We have a lot of tourists because it's a very old town. Here it's in the middle, more to the south of Germany, as you can see. I'm a cardiac electrophysiologist. We do a lot of ablations in our clinic. Here you can see the control room of our cath lab. And the presentation is about SPAF, which means stroke prevention in atrial fibrillation. As everybody knows, atrial fibrillation increases stroke risk a lot. If you select the patients, you can lower the stroke risk by 2/3 by giving oral anticoagulation. That's what we do since many years now. The use of NOACs, of the new anticoagulants, strokes the risk even further. As you can see, for every of the new substances, we have studies showing that the embolism risk is further reduced. And for this topic, there is a guideline which is very new. It's from August 2020, so it's 2 months old. It's from the ESC, and that's the guideline for the diagnosis and management of atrial fibrillation. So in this about 80 pages guideline, and it contains very detailed information about the topic. First, it's based on the CHATS-WAS score. The recommendation in this guideline is all based on the CHATS-WAS score, but there is a discussion in it what are the advantages and disadvantages of this CHATS-WAS score. First, what is the CHATS-WAS score? Everybody knows the CHATS-WAS score. It contains as a point system. You give points for congestive heart failure, for hypertension. You can give 2 points for 70 years or older, and 1 point for age 65 or older, 1 point for diabetes, 2 points for prior stroke or TIA, for 1 point for vascular disease, and for the sex category 1 point. Now let's see what's the recommendation of the new guideline. You should use the CHATS-WAS clinical stroke risk score. First step is to initially identify patients at low stroke risk. That means 0 non-sex risk factors. That means 1 in women or 0 in men. These patients should not be offered antithrombotic therapy. Then the next step is look for higher risk patients. That's more than 2 or more than in men or more than 3 in women. Those patients should receive oral anticoagulation. Then the intermediate patients, you can see that the first recommendations are class 1 recommendations. The CHA2DS2-VASc score of 1 in men or 2 in women is an intermediate risk. The treatment should be individualized on the clinical benefit and considered. That's a 2A recommendation in the new guideline. Here. Then there's a scheme in the guideline. In patients with atrial fibrillation, you should look if it's valvular or non-valvular fibrillation. In patients with valvular fibrillation, you should give vitamin K antagonists with in the therapeutic range here. And in the non-valvular group, you should identify the low-risk patients. That means calculate the CHA2DS2-VASc score. When 0 in males and 1 in females, you should give no antithrombotic treatment. Step 2, in patients with a high score, then you should also calculate the Hess-Bled score. Whereas the guideline says, I will show it later, the Hess-Bled score is not a reason to withhold anticoagulation. In a high CHA2DS2-VASc score, it is recommended, and the intermediate should be considered. So the topic is about the risk score system. Is it time to renew? We had the CHA2DS2 score, which was introduced in 2001. I think you still know this score system. It was then merely the first score system for calculating the clinic risk. Then it was renewed 2010 with the CHA2DS2-VASc score. We have newer scores like the ABC score, which I will explain later. We have other scores which were used in studies, but not really in the guidelines. The CHA2DS2 score was improved 2010 to the CHA2DS2-VASc score. This step brought that the intermediate risk group could be significantly reduced. Before, in the CHA2DS2 score, 69% were intermediate risk. Afterwards, 15% were intermediate risk by applying the new score. 9% were low risk score, and the CHA2DS2-VASc score says the low risk group has no risk for stroke. The CHA2DS2 score, the old score, had 1.4 in the low risk group. Here's a table which yearly stroke risk you have to expect applying to the CHA2DS2-VASc score. You can see that 0 in the low risk group, 1.9 or above in the high risk group, and 0.7 in the intermediate risk group. Then the Hess-Bled score was recommended in the old guidelines and is still in the guidelines, but it should be calculated. The idea is to give further stratification which patient could get anticoagulation and which patient not. It consists of the uncontrolled hypertension, abnormal renal or hepatic function, stroke, bleeding history, labile INR, elderly, or drugs or excessive alcohol drinking. So there are still more risk factors for bleeding, but that's the HAS-BLED score. And the new guidelines say you should, if there's not an absolute contraindication to oral anticoagulation, the HAS-BLED score plays no role in withholding an anticoagulation treatment. So for the practical aspect, the CHEDS-VAS score is good for identifying low-risk patients. It's good for identifying high-risk patients. But what's with the intermediate risk patients? That's where the CHEDS-VAS score underperforms. There are several registers who just calculated the CHEDS-VAS score and looked at the clinical result, and you see that there is a big variation here. And in the table before, I showed you 0.7%. Here the median is 1.6% over several registers. So for this field, the CHEDS-VAS score is not very reliable. Another topic is that the NOAC have lower bleeding risk and better efficacy than warfarin, and the old CHEDS-VAS score was developed in times where only warfarin was available. So if you have a lower bleeding risk and a better efficacy, you can give patients already the treatment when they have a lower stroke risk than before with a higher stroke for warfarin. So in this article that was calculated, it's reasonable to give for 1.7% per year stroke risk warfarin, but even for 0.9% per year the NOAC treatment to get clinical benefit. Another aspect is that patients with 1 point in the CHEDS-VAS score have a very high probability to get more points in the year after diagnosis. You see that here there is annual rate for new diagnosed risk factors, which shows here that over the time you have an incident for an increased risk factor which goes up to 30% after 5 years. And that's a very recent study where patients with a CHEDS-VAS score of 0 or for men or 1 for women were given anticoagulation, and you can see that the group itself also profited from receiving anticoagulation. So we need a better risk stratification for the intermediate risk group. So when the CHEDS-VAS score is not the best system, what could we do else? So we have to look at the risk factors for stroke and atrial fibrillation. Here's the classic risk factors which are included in the CHADS-VASc score and which are proven very well in many studies. What else do we have? We can use clinical risk factors. For example, the renal function can be very important. Smoking, for example, malignancy. We can use imaging or biomarkers like echocardiographic results. If somebody has a thrombus in the LA, he probably has a high risk. We can biomarkers in the blood like troponin, D-dimer. I will explain later. So we have a huge variety of risk factors for calculating the stroke risk, but for the individual patient or for a score system, this is sure too complex to take all in account. So we need a more simple system. Here's another work where we have a hazard ratio for several parameters. Here the heart failure. Here's also the a severe kidney disease has a certain hazard ratio. What I found interesting is that the smoking status plays a role here for a stroke risk, but also here the region in the world had a big impact. So the thing looks quite complex. What you could take in account is the atrial fibrillation burden. Here we have also a recent work who shows that the higher the AF burden, the higher the stroke risk. But the new guidelines say explicitly that the clinical pattern of AF should not condition the indication to thromboprophylaxis. Here we have a work for the biomarkers, troponin, the proBNP, and the growth differentiant factor 15, GDF15, and you can clearly see that the higher those markers, that the higher the embolism rate, and the higher also the bleeding rate. Another score system which was proposed in 2016 is the ABC score, and here you see a nomogram where you can calculate points. Sure, you can also take an online calculator for that, but here you see troponin is important, the BNP is important, age, prior stroke, and then you can calculate here embolism rate and also a bleeding score. And for the group of CHADS-VASc score is with a medium of 4 and smaller than 3 and higher than 5, you see that the accuracy was better than the CHADS-VASc score. But still, this is a group where the indication for oral anticoagulation is given by the CHADS-VASc score very reliable. So we need data for the intermediate risk group, and this is still ongoing. That it's a clinical trial where the ABC score is evaluated. So, is it time to renew? Yeah, the risk discrimination in the intermediate group is not sufficient at the present score system. Contra renewal, the CHATS-VAS score is simple. You can use it if, for example, if you are practitioner and you have a patient with ECG of new atrial fibrillation, you can calculate the risk instantly. You only need clinical factors or diagnosis, and you can calculate it by head. You don't need an online tool or something, and you can start right away with the anticoagulation. Whereas biochemical markers or echocardiography is often not available instantly. So you need a little time, but here you can decide immediately. Clinical data, and it's a good tool for the majority of patients. For low and high risk patients, which are the majority, it's very precise. Then we have the very new guidelines of the ESC, which has a strong recommendation for this score, and there's a huge amount of data. And we don't have a better alternative. The studies for the ABC score, for example, are still ongoing. We don't know really if it's much better. So the renewal is appreciated, but at the present, we don't have a better score than the CHATS-VAS score. This is my opinion, but in the future, there will be a renewal for sure, but not at present. That's a view of an old bridge in Bamberg, and thank you for listening.
And I would like to ask you a question. My question is, there are very exact guidelines for the management of anticoagulation in atrial fibrillation. What about atrial flutter? What recommendation apply here? Thank you.
For atrial flutter, we have also guideline recommendation. The problem is that we don't have that many studies as for fibrillation for flutter. And we have different types of flutter, and the diagnosis of the type of flutter itself is not so very easy. We have the typical flutter in the right atrium, and we have atypical flutter in the left atrium. And it is supposed that as the movement of the atria is more regularized in the flutter patients, that the risk for giving an embolism is lower than in atrial fibrillation. The normal habit was to treat flutter as fibrillation. We have the guidelines for atrial fibrillation in 2016, which say treat flutter like fibrillation for the aspect of anticoagulation. So we should treat flutter patients like fibrillation patients. Then there was a new guideline for the treatment of supraventricular arrhythmias from the ESC, which is also 1 year ago, and it said we don't have enough data to recommend oral anticoagulation for flutter patient. You decide on an individual basis, but you don't have any recommendations for that for the practical use. So, and in the very recent atrial fibrillation guidelines 2 months ago, it's again a clear recommendation to treat flutter as fibrillation for the aspect of anticoagulation. It becomes more difficult for patients who get ablated for right atrial flutter, because you think that the success rate for the tricuspid ablation is like 95%. So the patient is cured. For those patients, you can probably withdraw the anticoagulation after 1 month. But on the other aspect, you have a high risk for getting atrial fibrillation in those patients. So it's still not clear how to treat in this special circumstance after tricuspid ablation.
Thank you for nice presentation, Dr. Alexander. I have one question. My question is, after successful pulmonary vein isolation, can oral anticoagulation be withdrawn?
That's also an aspect which has been discussed many times in the past. The first thing is that we don't know if the fibrillation is cured from the ablation. So what is a successful pulmonary vein isolation? You can say if there's sinus rhythm after 3 months is successful, but in reality, you know, there are many atrial fibrillation episodes which come later, so you are never sure if the patient is really cured from atrial fibrillation, and the guidelines recommend to give oral anticoagulation according to the CHA2DS score before and after ablation. So if you have patients with an intermediate score, you can probably withdraw after 3 months.